When people think of using the Mackenzie method or MDT for patients with low back pain, they think of using extension for those patients. And while it's true that low back extension is what most people need to resolve their low back pain and associated pain and resolve their signs, there are definitely patients that need other movements. For example, side glide to the left or to the right, rotation and flexion to the left or to the right, flexion, and some others, but those are the main ones. So today I want to highlight a recent case report that details the 5 visits over 14 days of a young man who needed a form of flexion or forward bending to resolve his low back pain and associated signs. So it goes through the repeated movement testing briefly over his course of care. The title is Flexion Directional Preference in a Patient with Low Back Pain, Utilizing Mechanical Diagnosis and Therapy, a Case Report. And again, the term directional preference means that this is a mechanical joint problem and there is a direction that the patient can move into repeatedly to resolve the problem. There are definitely other disorders of the back, but when I use repeated movement testing to evaluate a patient presenting with complaints associated with the low back, I find that 70 to 80% of patients will have a directional preference. They will have a direction that their body prefers to move into to resolve the problem. And for the other 20 to 30% of patients, we are trying to determine the specific diagnosis and match the appropriate treatment to that diagnosis. For a diagnosis of joint derangement, the treatment is moving into the directional preference repeatedly. And then at the end of the care, returning to movement in all planes and all function as normal. Mechanical diagnosis and therapy, again, a mouthful, MDT, also known as the Mackenzie method. But when we think about MDT, I really want people to just think repeated movement testing, meaning you can do all the tests that you learned in orthopedics, all the tests you learned in school, like lumbar instability tests, or even palpation tests that don't have great reliability, and of course, nerve tension tests, range of motion tests, and strength testing. But we add repeated movement testing to our orthopedic evaluation when we say that we're using the Mackenzie method. That's the big distinction. And of all the tests we use in orthopedics, including imaging, I would argue very firmly that repeated movement testing is the number one test to use to arrive at an orthopedic diagnosis. So published by Greer, Tranquillo, and Maccio in 2022 in JOSPT Cases, that's the Journal of Sports Physical Therapy Cases. The abstract is available online. So they had, in this case study, a 28-year-old male presenting with low back pain, and a year prior he had had low back pain and had presented to the same clinic, I believe, and it was determined that his directional preference for his low back joint derangement at that time, 1 year previously, was extension. So he had kept up with some extension on a regular basis. He had adopted a standing desk, so he was more in a neutral to extended posture versus a flex posture and sitting at work. And he did some weightlifting that involved some lordosis, some extension of the low back as part of the weightlifting maneuvers. So he presented with low back pain that had started that day. It was central. He noticed the pain come on after a squat clean. He noticed he was worse with standing, which is a neutral to extended posture, and better with slouching in sitting. So again, when we take the verbal history, we're listening for, are there clues as to what this person's directional preference is? Are they telling me in their history without knowing it themselves that they're better with flexion and worse with extension, or that they're vice versa, the other way around? Most people, because most people respond to extension, are reporting that they're worse with flexion-based activities. Slouch sitting or prolonged sitting, car rides in bucket seats, gardening, bending over, and therefore tend to be better in walking or standing. It's not always that cookie cutter, but when we listen for the verbal history and we ask the specific questions that are needed to elicit the correct information, I am starting to wonder, is this patient reporting there's a direction of preference for their joint, whether it be their low back, their neck, their shoulder, their knee, etc. So that's the short version of the specific verbal history. It was pretty concise since the pain had started just that day. Now, when we get to the orthopedic evaluation after the verbal history, part 2 is taking the baselines. They looked at range of motion of the low back, which has 4 planes of motion primarily. There's a moderate loss in forward bending or flexion, a moderate loss of backward bending, extension, and side glides left to right were full and I'm assuming pain-free. He presented observationally with an increased low back lordosis, so an increased extension of that S-curve in the low back. Repeated movement testing, part 3 of the orthopedic evaluation. This is the part where you could do other tests as well if you desire, but the clinicians in this case study, one was a diplomat in MDT, so the highest level of training in using mechanical diagnosis and therapy, and under him were 2 third-year PT students who had also taken Mackenzie's courses A and B, so they were probably very or well versed in using mechanical diagnosis and therapy because they were working under a diplomat and had some training. But when they did the repeated movement testing as part 3 of the evaluation, they found that repeated flexion and sitting, so forward bending seated in a chair, worsened the patient's symptoms and did not change the person's range of motion. So again, repeated movement testing is move repeatedly into a specific direction with a specific load, with a specific amount of force, and then reassess for cause and effect on the patient's baselines. Baselines being, in this case, range of motion loss in flexion and extension, and baselines being a presentation of central low back pain in terms of symptoms. So it's very cause and effect. How a clinician gets better at repeated movement testing, or at least one facet of that endeavor, is knowing which repeated movement test to do first to get the best answers, and which load, seated versus supine versus standing, and how much force as well. There are 5 levels of force. We start with the lowest amount that we can to avoid risk and to improve safety. And that's what they did here. They just had the patient bending with his own power. But because there was no effect mechanically, so no improvement mechanically on the range of motion loss, which is pretty profound if it's moderate loss, and worsening symptoms, because of that cause and effect response, they decided to look at flexion in supine, which is lying on the back and bringing the knees to the chest. They looked at flexion in supine. The patient reported his symptoms were better. He had decreased pain with range of motion now and improved range of motion. So all around, that's a better response. They did some clinician mobilization in that position. So the patient brought his knees to his chest and the clinician provided some more mobilization pressure to that at end range. And that's where they decided that that was the best response, a good response to test over the next 24, 48 hours, repeatedly over time at home, flexion and supine, 10 reps or so every 1 to 2 hours. And during this visit, they also looked at prone lying extension. So sustained extension of the low back by lying on one's stomach, propped up either on elbows or with the plinth elevated. I sometimes have patients put their hands on a chair lying on the floor. And that test we can use because it usually will tell us if the patient is a flexion responder. It's not 100%, but if we put someone into sustained extension and we think that they need flexion to get better, what do we anticipate by putting them into sustained extension? We anticipate their mechanical presentation and or their symptomatic presentation to get worse. And that was the case for him. So a lot of extension makes this patient worse. It gives us more credibility that moving into flexion will be the fruitful direction of preference. The patient came back at visit 2, reported he was 60% better. They looked more at flexion and supine to see if more flexion and supine was indicated. They did not see a beneficial response. So at that time, they decided to return to flexion and sitting, which in general is more load through the low back. It's obviously in flexion and sitting is obviously moving the trunk on the pelvis versus lying on your back, you're bringing kind of the lower extremities up over the pelvis. So it's a different load in that regard, but it's also more force with gravity being on your side and sitting to flex with more force. They tested flexion and sitting for repeated movement testing, saw it was beneficial. The new home program became flexion and sitting, still at a high frequency, every 1 to 2 hours probably. And flexion and sitting is easy to do. All you have to do is sit down and bend forward. It only takes 30 seconds to a minute to do a set of 10. By visit 3, he was still improving, getting more function back into his life. Visit 4, they added extension and standing to test the integrity of the healing. So if the lesion has healed, if the joint derangement is not vulnerable anymore, it should be able to tolerate movement in the opposite direction. So they added extension and standing, EIS, and his home program became doing the flexion that was fruitful, and also adding in some extension just to make sure that we can now move that joint in both directions without problems. And obviously if there's a hiccup, if the patient's noticing that he can't tolerate adding extension into his life at this juncture, that will be removed from the program to let it heal more and by doing more flexion, but he was able to tolerate it. And by visit 5, he was 100% and discharged. Again, this course of care was over 14 days. And the take-home message is kind of like I said at the outset, there are different directions of preference for people, and you find them by using repeated movement testing. And Audrey Long's study about which exercise, and doesn't matter which exercise we use for low back pain, I did a video on that quite recently, that demonstrated that the vast majority of patients with what we call low back joint derangements respond to some form of extension, over 80%. But there are people who respond to flexion. There are people who respond to lateral or side motions to the side. So by using repeated movement testing, we can figure out if you're one of those 70 to 80% of people who have a directional preference, and that repeated movement testing in those cases will tell us which movement the patient needs. It's testing. Sometimes, or very often, we don't get that exact movement that you need on day 1, or we have to change the load as you get better or as we get more intel over the course of the testing. But we hope to find that movement, if there is one, as soon as possible, of course, to make the patient have their normal range of motion, normal strength, normal nerve tension, pain-free status, and able to do whatever they want to do in terms of function. So check out this abstract online, or try to get this article if you can, and keep in mind that we use repeated movement testing to figure out if it's extension, but if it's not extension, we're figuring out if the person needs flexion or movement to the side.